Hello and welcome. My name is Daniel Helbling. I'm a medical oncologist. We are here at the ASCO update in Zurich 2013. Next to me stands Dr. Renner. He's a specialist for myeloma and lymphoma. Christoph, what were the practice-changing studies presented this year at ASCO 2013?
There was not really a practice-changing study. There were some studies confirming current practice or encouraging people to follow what we define or what we believe current practice is. So for instance, in diffuse large B-cell lymphoma and Hodgkin lymphoma, the question was asked, if a patient is in remission after first-line therapy, how should the post-therapy surveillance be performed? Should you do regular CT scanning, or should you rely more on physical examination, patient history, and on taking simple blood values like LDH? And the answer was that the identification of a relapse just by doing routine CT scans without the patient having any symptoms or abnormal findings is extremely low. So that this study, both for diffuse large B-cell lymphoma and Hodgkin lymphoma, would encourage to see a patient who is deemed to be in remission every 3 to 6 months, do a physical examination, take the history, and do only CT scanning if you have any evidence.
Okay, that's really new, because normally how often are the CT scans done here in Switzerland, for example? What do you guess?
Yeah, that's an interesting question, and I asked that in audience recently. We did a voting, and the vote was that most people follow the ESMO recommendation, which is that people should do or can do a CT scanning after 6, 12 and 24 months. Now, NCCN guidelines are very similar as well, 6, 12, 18 and 24 months, and these were the two most frequently used recommendations doctors seem to follow. So I think what we should restrict ourselves is from doing CT scans every 3 months, which is done in most studies, but outside the study it is not recommended.
So actually very few patients could be detected, or their recurrence could be detected by CT scan. How often actually were there situations where patients could be detected by CT scan?
So in this study with 644 patients, only 1.5%, which were 8 patients in total, were identified just by CT scanning without having any symptom which would otherwise have triggered a CT scan. So a very low number.
So symptom-free patients, they don't need a CT scan. Often they want to have their CT scan in order to be sure that nothing is going on. So how are you handling now this problem in the clinic?
Yeah, that's, I think, a difficult question. It's very easy for a doctor to tell a patient, I sent you to CT scan and then we discuss it afterwards. Because in most patients with diffuse large B-cell lymphoma and Hodgkin's, it will be a good result, so you can really reduce your time you talk to your patient. But I think what one should do is talk to the patient, tell him about the chances to detect a relapse just by CT scanning, which are low as we just discussed, and certainly discuss the issue about radiation exposure, which is still unclear to us what the damage might be. So I think if you take your time, it certainly needs more time to talk to a patient about the risk of doing a regular CT than just to send him to a regular CT. But I think we should take that time, discuss it. And if a patient then is still willing, or if a patient is pushing that he wants to have a CT, I still send my patients to a CT. So if they are anxious about, some patients come and say, look, I haven't had a CT scanning and I'm anxious, I would like to have another one. Then I talk to them, but if I see that I cannot convince them because they finally have to accept the decision, then I still send them for scanning.
So you say if you have no symptoms, there's about a 2% maximum chance that the recurrence is detected by CT scan, and you also have radiation exposure. Do you really want to have that?
Yes. So I do take a patient history, do the physical examination, which we should really do on a routine basis, and take standard lab values. In that study, it was the increased LDH, which was taken as a risk factor or which was taken as a factor to be determined.
Okay, good. That's really practice changing, but probably difficult to implement into practice, but it helps.
Yeah.
It surely helps when you have these patients in front of you. Were there any other interesting studies coming from the ASCO this year regarding myeloma and lymphoma?
Yeah, I think the new drugs, there were no studies, no big phase 3 trials which would allow us now to finally judge on any of the new drugs, but there were interesting phase 1-2 clinical trials on new drugs. And in lymphoma, we really have to look now at the B-cell receptor signaling pathway. And the main molecules involved in that seems to be the PI3 kinase and the Bruton tyrosine kinase. And with the PI3 kinase, it seems to be the isoform delta. And inhibitors of these PI3 kinase delta, idelalisib is a prime candidate of that group. They really have activity in a broad range of lymphoma. They really seem to prolong progression-free survival, and they have an acceptable tolerability or toxicity profile. And they have single-agent activity. They are now being tested in combination, and I hope that in 6 to 12 months' time we will know more about these substances. And the other group is the Bruton tyrosine kinase inhibitors, BTKs. There the front runner seems to be ibrutinib. And again, very low toxicity, very high single-agent efficacy, and future data will tell us about efficacy.
Okay, so they're not yet on the market, they will come. It's for indolent or aggressive lymphoma primarily?
Well, most of the studies are actually in indolent lymphoma, but for instance, the BTK inhibitor, there was at ASH an abstract where the molecular subtype of diffuse large B-cell lymphoma, which is called activated B-cell subtype, that especially in this subtype, BTK inhibition seems to have a value. So it's not only the indolent, it is an aggressive as well. And the nice thing is now that we have molecular typing of these lymphoma, and that there is no link between molecular pathway and drug we can use.
So, okay, but there are no certain mutations you want to screen for, and then you do give certain drugs. Nothing like this, like in other cancer fields we have at the moment.
Well, not yet, but that is certainly now coming. I mean, the GCB and this germinal center B cell subtype and this activated B cell subtype, they are so far done by most institutes by means of chemistry, but we know that the gene expression definition is more valid. So I think it will come in lymphoma now as well. We certainly have molecular markers like MYC translocation, BCL2 overexpression, but we do not have drugs so far which target one of these molecular events, but they are coming.
Okay, good, great. So loads of things in preparation for practice change, but no real practice change yet. Is this correct? So,
yes, I think that is the conclusion we can take from ASCO. In the myeloma field, it was very similar. All the new drugs, promising data, new antibodies, new proteasome inhibitors, new immunomodulatory drugs, but there was no study, I would say, which changed really practice right now.
Okay. Christoph, thank you very much. Very interesting. Great to have you here. Hope to see you next time. Bye-bye.
Welcome. Thank you.